Okay, so Assalamu alaikum. I hope so. You all fine. And today I will be starting our first lecture in the final year BDS examination revision series, basically. And this is a special series arranged just for the students of the final year BDS, so that they can study well in their exam. So let's basically start with the name of Allah Almighty. So yes, this lecture is basically not made by me. This is one of my teacher's lecture, so I will not take all the credit of this lecture. I The slides have been made by the my one of teacher of oral surgery department from my institute of health for my institute. So with the name of Allah Almighty, we will start. And so today's our topic is basically impaction. So first thing that comes in your mind is when you discuss regarding the impaction means something that has been not yet erupted into the dental arch. So the definition of the impaction is that impacted teeth is basically a tooth that has not been erupted yet into dental arch. However, its dental age has been passed away. The time about which it used to have to erupt has gone and hasn't yet erupted into the dental arch. Okay, now let's move towards our next slide. So, what are the indications for removal basically? Uh, what are indications basically for the removal of the impacted tooth? When you see that there is a tooth which is unrestorable, it has extensive caries and it can't be restored with the help of a restoration, then you have to remove it. Then if you see that you have to prevent any periodontal disease or like periodontitis or and then if the patient is complaining with pericoronitis and it is basically recurrent in nature and it happens again and again, then you need to remove the tooth. If there is a complaint of a cellulitis or signs and symptoms of abscess and osteomyelitis are seen, if you see internal external resorption of tooth or the adjacent teeth on the radiograph as well, then if your tooth is basically fractured and there is a line of fracture you can see in your tooth, or if there is any disease of the follicle including the cyst or tumor. Now it can also be a prosthetic region as well, tooth teeth impending surgery or construction of the prosthetic. And there can be also reason tooth is involved in or within the field of tumor resection. So whenever tooth is involved in tumor resection, you need to remove that tooth so that you can remove the tumor as well. So I hope so. The indications are very well self-explanatory. The most commonly you need to know the unrestorable caries, prevention of the periodontal disease, and pericoronitis. Other you can also add up if there is a question in exam that comes for the indication of removal of impacted tooth. You need to write these 9 points. Now, what are the nice guidelines? So this is a very important thing. This can be asked in your exam as well as viva. The evidence suggests that a first episode of pericoronitis, unless particularly severe, should not be considered an indication for surgery. Second or subsequent episode should be considered the appropriate indication for the surgery. So, what happens basically if you see a first episode of the pericoronitis, you need to ignore it. However, if it is severe, uh, then you you can also ignore it because it should not be considered as indication for surgery. However, if you have recurrent episodes of the pericoronitis, then you can consider it for the surgery, and then the indication for the surgery is very much prominent and appropriate at that time. So, in the first episode of pericoronitis, you don't need to do any type of the surgical indication. You don't need any surgery for it. surgical treatment for it. However, if there is second or subsequent episodes of the pericoronitis, then you need to uh, then there are proper indications for the surgery basically. So with that, we will move forward. Okay. Now we have assessment of impacted third molar, clinical and radiographic. So how do we assess the impacted third molar? We have to see them into the two things, basically clinically and radiographically. So how do we see them clinically and radiographically? In clinically, you can see that there will be a crown present uh, of the tooth. You need to see the clinically the crown picture, and then radiographically on the radiograph as well. Then you have to see the angulation of the your teeth, either it's mesial distal or the buccolingual, etc. And then you have to know its vertical height as well. It can be seen on the radiograph or the occlusal plane. Then there are the space between the second molar and ramus, anterior ramus. You need to see it, and this will be very much prominent in your OPG. Then you need to know the root morphology, how is the root shape, and then there are the numbers of the root, how much roots are present there. Mostly the mandibular molars have more roots, and maxillary molar can also have three roots as well. Uh, then you have to see their relationship with the interdental bundles. uh, Either the periodontal fibers are in good form or not. Then you have to see the density of the bone as well, how much the bone is being dense, and the age of the patient as well. So these are some of the assessment that you need to study while seeing the impacted third molar. You have to check these points clinically and both on the radiograph as well. Okay. Now moving forward, so, what is uninterrupted tooth? Basically, uninterrupted tooth is a tooth that is in the process of eruption and is likely to erupt based on the clinical radiographic findings. So, every tooth which has not been yet erupted into the dental arch and is basically in the process of developing or erupting, and and is yet to erupt into oral cavity, and you can see it by checking it clinically and by radiographic findings. You, you will say that this is basically the unerupted tooth. So what are the malpose teeth? Basically, the malpose teeth are the teeth that are basically unerupted or erupted, which is in an abnormal position in the maxilla or mandible. There are some of the teeth you can see that they are in misaligned, or they are not in the regular position. If you see them occlusally, or you can see that like that they are not in the regular form in the arch. So such teeth can be called as malpose teeth. Now moving forward to our next slide. Now, what is the impacted tooth? So basically, this lecture is about the impacted impaction. So we will keep more of our focus in on the impaction. So impacted tooth is a tooth that has failed to erupt completely or partially to its correct position in the dental arch, and the eruption potential has been lost. So any tooth which hasn't yet erupted, or which is in the process of erupting, but his dental age on which it needs to be has gone, it is called impacted tooth. It can either be your canines, it can either be your mandibular third molars or maxillary third molars. So all the teeth that have not been erupted yet into the dental arch, and their eruption time has been gone, are called as impacted tooth. It depends how much time they remain impacted. Some cases, patient can have a wisdom tooth, like in the later stages of life, like after 20 to 25 years of age, and they can have several episodes of pericoronitis, or you need to remove it surgically. So why tooth becomes impacted? This is a very important question that can be asked in your exams and viva as well, by the examiner. Because the lesion teeth, dense overlining bone, excessive soft tissue, or a genetic abnormality prevents eruption. So if such question comes in your exam, you need to write it in the points form, so that this question becomes extensive, and this you can get a lot of marks from it. Like you have need to first tell it because of decision teeth, because when you see them on radiograph, uh, uh, either it can be a second molar that in, that will be impacting the eruption of the third molar, or it would there would be excessive soft tissue over the third molar that would be preventing it from erupting. There could be dense overlying bone underneath it, and or there can be genetic abnormality which is preventing the tooth to erupt. So these are some of the points. And also you should remember that this is a very tricky question that can be asked, that impacted teeth is included in the unerupted teeth term. So basically impacted tooth doesn't erupt into the oral cavity, so it is included into the unerupted teeth. When it will be erupt, then it will no longer be unerupted teeth, because it why it is called unerupted teeth, because basically it is in the process of erupting. Okay. So now, moving towards the examination procedure, how do we examine it? By looking towards the patient face and doing his oral examination. Extraorally, we can see different things like the symmetry of his face and his soft tissue curvature and TMJ, etc. In oral examination, first we need to ask the patient about his past medical history. However, the patient age is self thing, self-explanatory thing that can let you know that either either the patient wants either patient has impacted tooth or not. Then there are pericoronal soft tissue. Okay. Then we have TMJ. So what uh, you can see the TMG as well. Then there are prostheses, fillings, and crowns on the adjacent teeth, especially second molar. You need to see these things as well on examination. You have to first you have to ask past medical history. Then you need to know the pericoronal soft tissue, if either it is he has pericoronitis or not, or then in the soft tissue you need to check the TMJ, uh, and then you have need to know the prosthesis as well, if there is prosthesis or not in the mouth, or and then fillings and crowns on adjacent teeth, especially the second molars can be seen. No, investigation. What investigations basically are required for the impacted tooth? Basically, you need to go for a periapical radiograph, which a PA radiograph, which are very much common for any impacted tooth. And then there is OPG. OPG is basically gold standard for multiple impacted teeth. So this can be asked in the exam. What is a gold standard technique for multiple impacted teeth? Basically, OPG is the gold standard for multiple impacted teeth. So then you need to go for the blood investigations as well, because you are expecting a tooth. You should take a great history of the patient, if either he is having a blood disease, or he is on a blood thinner or other such medicine that can cause problems. Then you need to monitor the blood pressure, INR, and blood glucose level as well. So these should be monitored as well, the blood pressure, INR, and blood glucose level in every extraction basically. So what are basically the indications for the removal of impacted tooth? Indications for the removal of impacted tooth includes prevention of periodontal disease, prevention of dental caries, prevention of pericoronitis, prevention of root resorption, impacted teeth under the dental prosthesis, prevention of odontogenic cysts and tumors, and treatment of the pain of unexplained origin, and prevention of jaws fracture. Okay, and facilitation of the orthodontic treatment. So what it is saying that you need to prevent the periodontal disease, you need to prevent dental caries, you need to prevent the pericoronitis, root resorption, and impacted teeth, which under the dental prosthesis, you need to avoid that as well. You need to prevent the odontogenic or tumors to develop to treat the unexplained pain origin, and to prevent the jaws fracture as well, and facilitation of the orthodontic treatment. For such purposes, you need to uh, remove the impacted tooth. Okay, so these are basically indications. Then coming to the contraindications of the removal of the impacted teeth, basically uh, the removal of the impacted teeth is contraindicated in these things. When the patient is of extreme age, like of very old age, then you can't remove this impacted teeth. Then compromise medical, if there are compromised medical students, probable excessive damage to the digestion structure. uh, the medical status of the patient is not good, and there is excessive damage to digestion structures. Okay. Now coming toward forward, what are the indications for the removal? So basically, again, you need to know this very much. This can come in your exam as well. What are the nice guidelines for the removal of the impacted tooth? When there are episodes of pericoronitis greater than 2 times, then you need to remove the impacted tooth. If the impacted tooth is grossly carious, untreatable pulpitis, there is untreatable pulpitis associated pathology, cyst, tumor, or carcinoma, jaw surgeries, osteotomies, orthodontic requirements. No prophylactic removal if asymptomatic. So I should advise with this thing with you a lot, again, because this is an important UQ. So basically, what are the indications for removal of the impacted tooth? And it can also come like, what are the nice guidelines for the indication for removal of the impacted tooth? When there are episodes of pericoronitis greater than 2 times, and if the tooth is grossly carious, if there is untreatable pulpitis, that you can't treat the pulpitis, if there is associated pathology like cyst, tumor, or carcinoma, or if there are jaw surgeries, osteotomies, and if there is orthodontic requirement, no prophylactic removal if asymptomatic. So basically, you don't need to remove it if it's asymptomatic. Only remove it when it is symptomatic. Okay, surgical procedure involves effecting the adequate flaps for accessibility, removal of overlying bone, sectioning of the tooth, delivery of the section tooth with elevator, preparing for the wound closure. So what? How do you remove it? Surgical procedure involve basically the adequate flaps for accessibility. First, you need to raise the flaps so that you can get the great access. Then you need to remove the overlying bone. Okay. Then you have to need to section the tooth. Uh, Remove the bone with the help of a burr. Then you need to section the tooth. Review section tooth with the help of a preparation for the mount layer. Then you need to close the wound with the help of a sutures. So what are you doing for in the first step? You are raising the flap and then making the accessibility great access. Then what are you doing? Then you're removing the overlying bone. Then you need with the help of the bird. Then you're sectioning the tooth. Uh, then delivery of the section tooth with the elevator, and then you are preparing the wound for the closure as well. Okay, so up till now, I hope so you are getting my point. So now coming towards healing of the extension socket. So what happens in the healing of extraction socket? How does the extraction socket heals? Extraction of the erupted tooth, incision with the gum flap folded back, tooth extracted in the sections, wisdom tooth removed, and suture closing the incision. So first you have erupted the first you have extracted the erupted tooth with the help of an uh, forceps and elevators and the tooth burr, and then you have a section the tooth basically and remove the overlying bone. Incision is basically given with the gum incision is given with the gum flap folded back. Then the tooth is extracted in sections with the help of an elevator, and then what you need to do is you have to suture the wounded area. Wisdom tooth is removed and the suture closing incision. So basically, this picture is self-explanatory. You can have an idea regarding it. So this is basically a jaw. Let's see the video. So in this video, as you can see that it was explained that third molars are last to erupt in the oral cavity. So sometimes they can erupt or sometimes they become impacted, like in the picture. As you can see that it was a horizontal impaction. And what it did, first you removed the soft tissue, raising the flap, by giving an incision and exposing the socket of the tooth. Then what did you did? What you removed the overlying bone, and you section the tooth with the help of the burr, and then remove the sections with the help of an elevator, and then you again sutured the wound area with the help of sutures. So by closing it with the sutures. So this was all that was tell in this picture. Now coming towards our classification of infections that are very much important. The first and the most important one that comes in your exams is Pell and Gregory classification. So there are different classification of Pell and Gregory, basing on the impaction depth as well as on the Ramus relationship. So this is one of the important picture in the exam that can, and that if you know, you can easily cover it on the basis of the impaction depth. Okay, the you can see that there is level A, level B, and level C. You can see that the depth of the tooth with occlusal plane and into the body of the ramus. Uh, in this picture, you can see that the distal mesial side of the third molar is being a little bit inside the body of the ramus, and in this picture only distal cusp of the tooth is basically a little bit exposed. However, most of the tooth is basically in the body of the ramus. Then coming towards the ramus relationship, what it is saying, that it is saying that according to ramus relationship, you can see that basically it is present in front of the ramus, and it is a little bit in the line of occlusion. And basically on the class 2 you can see that it is present very much anterior to the ramus, and it is little bit exposed. However, level C is basic in the class 3, it is below the ramus of the mandible. So you can see that according to the ramus of mandible, it can also be classified. Then we have the all-time favorite Winter's classification, based on the angulation of the tooth. There can be vertical, according to the occlusal plane, like this is vertically high, this is vertically low. Then you have to base them on the angulation as well. It can be mesioangular. The mesial cusp is basically towards the distal cusp of the second molar. Then it can either be horizontally placed as we saw in the video. Then it can be either disto-angular as well, disto-angular as well, disto-angular as well. Then it can be either buccolingual, or buccolingually placed, or it can there can be other type as well. So this was about the Pelling Regri impaction classification. So this is a little bit self explanation about these classes. In the class 1, there is sufficient amount of space between the ramus and the distal surface of the second molar uh, for the accommodation of mesodistal size of the crown of third molar. So basically, what is saying that there is a lot of this area present here. So for the mesodistal eruption of the tooth in here in this area in class 1. However, in the ramus and the distal surface of the crown, distal surface of second molar. So when we are talking about class 2, there is space between the ramus and the distal surface of the second molar is less than mesodistal the size of the crown of third molar. So what is saying that basically here you can see that the mesodistal width of the crown is more, and the space between the ramus of the mandible and the distal to the second molar, there is less space in the so that the mesodistal of the whole crown can erupt. Only the mesial side of the third molar is being erupted. However, third molar uh, distal cusp is basically in the ramus. However, here you can see that there was enough space for the mesodistal width of the crown to erupt into the dental arch. Now, in class 3, all or most of third molar is located within the ramus. Basically, in class uh, uh, 3, you can see that all the third molar uh, is all or little of the third molar is basically present in the ramus. So I hope so. The on the basis of the ramus relationship you have got, that if there is a space available of major distal for the crown to erupt, then it is class 1. If there is a the major distal width of the crown is not sufficient, and there is not space available for it, then you can see that it is not very much exposed into the oral cavity, and it can either be, it can also a little or either be fully below the ramus of the mandible as well. Okay, in position A and position B and position B, the highest point of the tooth is on the level or above the occlusal plane of the second molar. So it is saying that the highest point is basically above the second molar or occlusal on the level basically, or the occlusal plane of the second molar. However, in point B, the highest point of the tooth is below the occlusal plane but above the cervical line of second molar. So in class B, you can see that in the class A, it is basically on the level of the second molar occlusal plane. However, in class B, it is below the occlusal plane, but it is present cervical to the second molar here. However, in class C, the highest point of the tooth is below the cervical point of the second molar. It can be explained by the picture. You can see that the highest point of the third molar is basically lower to the lower to the occlusal plane, and it is cervical to the second molar, below the cervical line of the second molar. So basically, it is below the cervical line. Okay. So this was Palin Gregory's classification. It can be explained in this picture as well. Based on the depth, Palin Gregory point A, highest point of the second molar, and the third molar is in line. Basically, these 2 points are in line. Highest point in line. And position B, in you can see the highest point of the third molar is between the plane of the occlusal and cervical line. So it is basically present between the cervical and the occlusal line here. This one is the highest point here, and this is occlusal plane, and this is basically cervical line. And what is the position C is telling you that the highest point of the third molar is below the cervical line. highest mo- uh, Highest point of the third molar basically is below the cervical line. You can see that this is cervical line, highest point is below it. So you need to remember these. Point A is in the line, or in however in point B, it is present between the occlusal and cervical line. However, in position C, it is basically present below the cervical line. Now coming towards the Palin-Gregory classification of mandibular third molar based on the space available to the second molar, which I told you that class 1, class 2, and class 3. So there are two types of the classification of the Palin-Gregory. One was on the basis of the depth, and one was on the space amount of the space available distal to the second molar. In the distal to the second molar, we have to first study class 1. In the class 1, you can see that the amount of the space is sufficient shade available between the anterior border of the ramus here and the distal side of the molar. So for the eruption of third molar, so third molar can easily erupt here. In the class 2, you have seen the space available between the anterior border of the ramus and the distal side of molar is less in the width, mesodistal width of the crown of third molar. So basically, the space available here is less as compared to the mesodistal width of the tooth. So not whole of the tooth will be erupted. You can see that only the mesial side of the tooth is being erupted. In the class 3, you have seen that the third molar is totally embedded in the bone from the ascending ramus because of the exclude lack of space. What happens in the class 3? The thing happens in the class 3 is that the whole of the tooth is being embedded into the ramus of the mandible because there is a lack of space for its eruption. So this was a Palin-Gregory classification of mandibular third molar based on the space available distal to the second molar. Then we have classification of maxillary third molar based on occlusal plane. Then there is same class A, class B, and class C. Occlusal plane of the impacted tooth is on the same level as adjacent tooth. As I told you that this is a class A. Both the impacted tooth and the second molar tooth are on the same level. However, in the class B, the occlusal plane of the impacted tooth is between the uh, occlusal plane and cervical line of the suggestion. Basically, if this is the cervical line and if this is the occlusal line, so the occlusal plane will be fall in between them. So this will be class B. Okay, and then if you are studying the class 3, then the occlusal plane of the impacted tooth is apical to the cervical line of the distant tooth. So what happens in the class C, the uh, your occlusal plane is basically apically, like present below the cervical margin of the second molar tooth. Again, depth and relation of the ramus, if you can see that level A on the same level of occlusal plane on the second molar, level B below the occlusal line, and above the cervical margin. So, and level C below level C apical to the second molar. So what happens here is then you have when you see the relation to the ramus, it is class 1 if the crown not covered with the bone, and if it will be class 2, crown half covered with bone. How what happens that if you have a little bit space available, so that it can accommodate medial distal width of your tooth. So then it will be class 1. If there is not sufficient space, a little bit space available, then there will be half of the tooth will be half of the crown of your tooth will be covered with the bone. And on the class 3, you can see that the whole bone is being above the your third molar, and your tooth is highly embedded into the bone. So this was a relation of the ramus and depth of the ramus, and this was all about the Pell and Gregory classification basis on the basis of the depth and on the basis of the relationship to the ramus. Now moving towards the winter lines, what are the basically winter lines? These are very much important and can be asked in your exam as well, and it can also come in your MCQs as well. So winter lines, you see that the position and depth of the tooth can be accessed with the help of intraoral X-ray. So what happens when you go for an intraoral X-ray, you can see the position and depth of the tooth uh, which is being impacted. So there are basically three imaginary lines that you need to see, and which are basically drawn, and these are known as water winter lines. So this can come in your MCQ, and this can also be asked in your SCQ as well. What is white line? White line is correspond to the occlusal plane. In you can see that in this picture, this is white line. So what the white line is indicating, it is indicating that corresponding to the, it is basically corresponding to the occlusal plane here. So the white lines correspond to the occlusal plane, and amber line represent the bone level. So what amber line is indicating, it is representing the bone level here. And then we have a red line. Red line is drawn perpendicular from the amber line to an imaginary point onto the application of the elevator. It indicates the amount of bone to be removed before elevation. So we need to assess these lines so that we can remove the impacted tooth. White line is basically telling us the occlusal plane, as I told you in this picture. This is your occlusal plane basically, and amber plane is telling you the your bone level. So how much it is above the bone level, and then you draw the red line perpendicular from the amber line to the bone level to the amount of the elevator where you grasp your elevator and remove the tooth. So it can be explained with the help of this diagram very much, that this is white line and it is letting you know the occlusal plane. Here your teeth are in occlusion. And then this is amber line. Amber line is telling you the amount of the bone level. So this is the alveolar bone. As you can see that third molar is being impacted here. And then there is red line. And you should know that we have drawn the red line from the level of our bone here from the amber towards our the elevator. So how much we need to uh, 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 elevate it, so that we need to remove it. So it will let you know that how much you need to let go your elevator, so that you need to remove it. Then you can see that this is the segmental enamel junction and point of application. So whenever you will extract the third molar, you need to know the line, the distance between the your point of application and to the amber line. Okay, so as the amber line was indicating the bone level here, and then this was the distance between the point of application of your forceps. So this is basically the red line is indicating the distance between the amber line and your point of application of forceps. So this was mesioangulation. You can see that mesial cusp is present here, and then this is distoangular. Okay. Again, this is white line is indicating the occlusal plane, and your amber line, your yellow color, which is indicating the bone level here. You can see that the bone is occlusal level and bone level are here. So the bone is level is starting from here. The red line start from here, and then how much you need to extract the tooth. The point of application of the forceps is here. So the line is indicating the distance between the your point of application as well as the bone level. Same as the case in horizontal tooth application and vertical. So these are the diagram is illustrating white lines when applied to unerupted wisdom teeth in the different position. I hope so. So far, you all guys are getting my point. Now moving forward, next slide. Yes, what are the winter lines? Basically, you need to know this, that if your red line is about this millimeter, when you need to extract it in the LA, or when you need to extract it in the GA. When your red line is less than 5 millimeter, then you need to extract it in the local anesthesia. It is easy and you can extract in the local anesthesia. But if red line is above 5 millimeter, which was line from the occlusal plane towards the point of application of forceps, then it is difficult and you need to extract it in a GA. And increasing 1 millimeter makes difficult threefold. Basically, if it's 6 millimeter, you can see that the removal of that tooth will be threefold difficult as compared to the tooth which was less than 5 millimeter. So if the length of the red line is more than 5 millimeter, then the extraction is difficult, as I told you earlier. And every additional millimeter renders the removal of impacted tooth three times more difficult, more than 9 millimeter. Just this was just for an MCQ, and it can be asked in the Viva as well. Okay, in which about till which millimeter you can remove it under LA. So you should know that below the 5 millimeter you can. This is easy extraction and you can remove under LA. Above the 5 millimeter you need to remove under GA. And after 5 millimeter each increases, the difficulty fold increases threefold. Then we have a classification of the impacted maxillary canine as well, because along the all the tooth in the our dental arch, the canines also become impacted. So you should also know that. And this question comes in exam, and most of the student don't know its answer, because the one problem is this, because they don't know the answer, because in your tucker there will not be present the classification of impacted maxillary canine. If you want it, you can read it from the internet, and you can get my slides as get these slides as well. And you can also study it from the Nilma book as well. It is written basically in Nilma. So what is saying that in class 1 parity placed maxillary canine. So in class 1, the maxillary canines are basically parity placed. It can be either horizontal, vertical, or angulated. In an angulated, it can either be mesioangular, distoangular. However, in class 2, the canines can be either labally or buccally placed. They can be either labally impacted or buccally impacted. And they can either be horizontal in position, vertical, angulated. Class involves both the buccal and palatal bone. For example, the crown is placed on the palatal aspect and the root is towards the buccal alveolar aspect. I would love to draw a picture for this. This is a this is your maxillary canine, like this. And you can see that in this picture, it's if this is your buccal, buccal bone here. Then it what would we say that your crown side, sorry, this is the crown side and this is the your parietal aspect. And this, if this is your root, so it will be tilted like in this way, and your root will be on the buccal aspect, buccal alveolar process, and however your uh, crown will be on the parietal aspect. So it will be impacted in this manner. So it is telling you like class 3. So you should also always remember these classes because it can come in your MCQ. In class 4, vertical impacted canine in the alveolar process between the lateral incisor and first premolar. So what happens? Impacted canine is basically vertically impacted in the alveolar process between the lateral incisor and first premolar. So this is lateral incisor, and this is first premolar. So what happens? The impacted canine will be vertically impacted, like in this way. If this is the your occlusal plane, and all the tooth are being erupted, it will be below the occlusal and cervical plane of the tooth, all the remaining tooth, and it can be impacted in this manner. I hope so. You guys are getting my point. In class 5, what happens? Canine is impacted in the edentulous maxilla. So it can also become an exam to tease you or to check you that if the canine is being impacted in the edentulous maxilla, what type of class it is. You should remember that this is class 5 because most of the people get confused with the edentulous term. Uh, if a patient has a edentulous maxilla, has no teeth in his maxilla, then the canine is being impacted, then it will be the case of class 5. Similarly, in the class 6, maxillary canine is in an unusual position, for example, in nasoantral wall or infraorbital margin. Like if you see a person here from the facial point of view, the patient, and you do an OPG, you can see that the patient has its maxillary canine present near the nasoantral wall here, or it is present below the infraorbital margin here. So, in such impactions can be seen on the OPG or your lateral ceph. So you need to know that this comes under the class of the class 6. Now, mandibular canine impaction, they are very much less as compared to maxillary, and they are very much rare as well. So if they can be either labially, in the labial side, you can see that they can be either vertical like this, they can be oblique and other angle or pattern, and they can be either horizontal as well. What happens in aberrant? It can be either present in inferior border on the opposite side. You need to know how whenever you need to study the impaction or see the impacted tooth, you should go for an OPG because OPG explain better where your tooth is being lying. It can either be very much close to the your inferior dental canal or nerve, as well as mental nerves and other vital structures as well. So this is the very much common important classification of maxillary canine as explained earlier, but I will explain you again with the help of the diagram as well, so that it becomes clear. In class 1, you can see that impacted cuspid located in palate. You can see that in this picture, this is showing the impacted cuspid here. Sorry, here. Sorry, here. This picture is, this is the impacted cuspid, and it is present parallelly, and it can either be horizontal position, in vertical position, and semi-vertical position. However, in class 2, you can see that this tooth is the impacted cuspid and is located labially. It is basically located labially or buccally to the surface of the maxilla. It can either be horizontal, vertical, semi-vertical. However, in class 3, you can see that impacted cuspid is located in palatine maxillary bone, in this palate bone or maxillary bone, and the crown is on the palate, and root passes through the root of the adjacent teeth and ends on the buccal ribs. So what happens? Its crown is on the one side and the root is on the other side. Basically, one is facing the buccal surface and other is facing the parietal surface. And in class 4, what is happening? Basically, it will be present in the edentulous maxilla. Sorry, the class 5 will be present in the edentulous maxilla. And in class 4, what happens? The impacted cuspid located in the alveolar process, usually vertically between the incisors. Basically, you can see that it is impacted vertically in this position between the your lateral incisor and the first premolar here. So there is no space for the maxillary canine to erupt in the oral cavity. So these are some of the indexes. These are not very much important for exam purpose, but you should remember a little bit for your MCQs as well. Maxillary third molar difficulty index. It tells you it tells you the difficulty index in removing that maxillary third molar. So what happens? The opposite of mandibular third molar, basically vertical, distoangular, this person, these are easier to remove due to less bone removal. So basically, these type of index, when you find they are easy to move due to less bone removal. However, in mesioangular or buccal easier than the parietal. Divergent thin conical bone difficult. Whenever there are more than one roots, then there is difficult to move it. Buccal expected easier than the parietal, and when there is more bone coverage and soft tissue density is more, with relationship maxillary sinus and tuberosity, they become very difficult. So these are some of the indexes which has been assigned. So you need to remember them so that you can get the index and need it for the surgery. Either you can do surgery easy or not. Basically, if the index falls between 2 to 4, then it will be minimal difficult. If it falls between 5 to 7, then it will be moderately difficult. And if it is 7 to 10, very difficult. These are the index that you need to remember. If it's class 1, then it will class, the index will be 1, class 2, then index will be 2, in class C, index will be 3, level A 1, level B 2, level C 3. And if it's mesioangular 1, mesioangular tooth is very much easier to remove. However, distal angular is the most difficult to remove in the oral surgery. So do remember this, that distal angular has the 4 index and it's very much difficult to remove. And horizontal case 2 and vertical 3. So what happens in complication? Complication includes injuries to digestion, teeth, and structure. You can damage other vital structure and nerve, etc. There is pain and swelling. You can have TMJ injuries, alveolar osteitis, soft tissue burn, crush injuries to lip, etc. You can have hemorrhage, local and systemic factors as well, and OAF and local and static related neurological problems as well. So these are some of the complications that can be caused. You can have TMJ injuries, pain, swelling, injuries to the vital structure, alveolar osteitis, soft tissue, hemorrhage, local and static rating, neurological, and etc. So this was all about today's lecture. I hope so. It was useful for you guys, and you learned something from it. See you in another lecture tomorrow, inshallah, with a very new lecture, and that will be also important for the final year BDS as well. So do let me know in the comment section or chat if you want another topic or specific topic that you need to cover. So till then, stay tuned. Khuda Hafiz.